Good morning, everyone. Thank you for coming down. Today, we have started to come down in order to learn a little bit more about white blood cell cancers in honor of Blood Cancer Month. Today, we have three distinguished speakers coming down to talk to you about the various blood cancers. And we have the opening speech from Prof. Eung-Haeng Ju, head of department at the hematology in Singapore General Hospital. I'll give the floor to Prof. Eung-Haeng Ju and let you speak.
Thank you, Tertius, for the introduction. Now, on behalf of the Department of Hematology at Singapore General Hospital, it's my pleasure to welcome you this morning to this webinar on white blood cell cancers. I think most people don't recognize the blood as an organ of the human body, but it is indeed an important organ in the human body that has got varied functions that are carried out by its components, which are the blood cells. This includes the carrying of oxygen by red blood cells, the defense mechanism, which is mediated largely by white blood cells, and also platelets, which are responsible for preventing bleeding. Blood also has components of proteins, largely made up of immunoglobulins or antibodies that helps us fight off infections and perform other bodily functions. Like any other organs in the human body, the cells of blood has the ability to transform itself. And unfortunately, there are occasions whereby the transformation of the cells leads to disorders that then causes the cells to become malignant, or what we define as being cancerous of the cells. And there are many forms of blood cancers that we recognize. Unfortunately, the term cancers usually connotes fear among people, among patients, and so on. But suffice to say that cancers, blood cancers in particular, spans a whole spectrum of conditions, from those that are benign, where it has no effect on the life expectancy of patients, to those highly aggressive conditions where, without appropriate diagnosis and treatment, patients can succumb within a short period of time to the aggressiveness of the condition. So this morning's webinar will be focused on white blood cell cancers. And here at the Department of Hematology in Singapore General Hospital, which is the biggest hematology center in the whole of Singapore, we have more than 30 blood specialists or hematologists specializing in different aspects of care of patients with blood disorders, including blood cancers and cell therapy, as well as transplants, that offers a wide spectrum, a whole suite of services for the diagnosis and treatment and care of patients with blood cancers. And with me this morning, I have three of my colleagues, Dr. Lawrence Ng, Dr. Nurul Aida, as well as Dr. Melinda Tan, who will be taking you through a series of short lectures on three selected topics concerning blood cancers. And we hope that they will be able to shed some light on the conditions that they will be discussing with you this morning. And this is relevant as we appreciate Blood Cancer Awareness Month, which is usually designated for the month of September every year. So I wish that you will have a fruitful and informative next hour and a half or so with the topics that will be presented by my colleagues, and that you will be left with additional information and understanding about blood cancers and the progress that we have made over the past decades, where in many situations, blood cancers have become more easy to diagnose, and we are able to offer treatment, which in many instances have provided for longer-term control of blood cancers, and in many other situations have offered opportunities for cure for patients who have been diagnosed with blood cancer. So I wish you informative and a fruitful morning with us on this webinar on white blood cell cancer. Back to you, Tertius.
Okay, thank you, Dr. Ng. So today I'd like to introduce Dr. Lawrence Ng. He is a consultant at the Department of Hematology at Singapore General Hospital. Today his topic will be on lymphomas and the overall management of those. I'd like to welcome Dr. Lawrence Ng.
Thank you, Tertius, for the kind introduction. So, good morning, everyone. Let me show the screen. Okay. All right. So, my topic is how do we manage lymphoma in 2022? So, let's start. So, what is lymphoma? And so, lymphoma is a blood cancer. It arises from the lymphocytes. And what is lymphocyte? Lymphocyte is a type of white blood cells that found in every part of our body and predominantly in the lymphatic system. So lymphocytes are actually good cells. They are immune cells protecting us from getting infection, including virus, bacterial, and fungal. So they actually migrate one place to another place depending on the need, and they could sometimes switch on and off depending on their specific tasks. So, however, when a specific lymphocyte soldiers and divide in an abnormal way and do not die as according to their should do, and they become a cancerous, it become a lymphoma. So this is just example of lymphoma under the microscope. So how do we usually diagnose lymphoma? We need to look under the microscope, looking at the cells and see how's the characteristics of them being different compared to a normal lymphocytes or lymph nodes sample. So lymphatic systems are actually all over our body. As you can see in the picture here, it is actually cover all parts of our body. And especially the lymphatic system are concentrated in those areas that is being repeatedly exposed to outside trigger. Example, your neck, because your oral cavity is always exposed to foreign body, including germs. Your intestine system, your groin, in the groin regions, the armpit, as well as the spleen. So spleen is actually part of the lymphatic system. So what causes lymphoma? Unfortunately, in a lot of the cases, the cause are unknown. Some of the lymphoma are associated with viral infection, HIV, EBV, hepatitis C, and some of the lymphoma are associated with bacterial infections, such as the H. pylori causing the gastritis the problem. Some of the lymphoma are associated with a solid organ transplant, autoimmune diseases, or low immunity state when you caused by certain diseases or certain drugs. And majority of the lymphoma are not hereditary, so we don't see a pattern running in the family. Symptoms of lymphoma, it really depends on the site of the disease. So it could present as a lump over the neck, armpit, or in the groin. And it could also just swell up inside your chest or your abdomen. And in that case, we only can pick it up on the CT scan. So when you affect the normal function of the specific organ, then you will experience the related symptoms. Example, if the lymphoma tumor is compressing on a urinary tube, and that can cause kidney failure, reduce in your urine volume. And if lymphoma occupy the bone marrow, it will cause bone marrow failure. So you are suffering from bone marrow failure symptoms. There were a group of symptoms, we call it constitutional symptoms, that include fatigue, extra fatigue, loss of appetite and weight, fever, night sweats. So those are actually can be signs of lymphoma. lymphoma can happen anywhere, I mean everywhere. So they are also occurring in places, rare places like your brain, your eye, and your skin. So this is just an illustration of the symptoms of lymphoma. Beside the fatigue, loss of appetite, weight loss, fever, it can also cause enlargement in the lymph node that sometimes can be visible, or certain organs dysfunction, depends on the site of the disease. So types of lymphoma. There are many types of lymphoma. Over 60 types of lymphoma worldwide. But of course, in the commonly that we see in Singapore, over about 40 types. How do we group them? We broadly group them into Hodgkin lymphoma and non-Hodgkin lymphoma. So, and under the non-Hodgkin lymphoma, they are also divided into B type and a T type. So under each group, the B and the T, they also subgroup into a slow growing, which is called a low-grade lymphoma, or a fast-growing aggressive high-grade lymphoma. Of course, there are times to time, in rare occasions, the low-grade lymphoma can transform into the high-grade lymphoma, called a transformation. And also in the rare, very rare situations, sometimes different subtypes of lymphoma happen in a single patient. So these, I picked it up from the US registry. So as you can see, a majority of the cases are actually non-Hodgkin lymphoma. So the diffuse large B-cell, the chronic lymphocytic leukemia, and the follicular, they are all the non-Hodgkin B-type lymphoma. So and there are also some rare cases like T cells, and Hodgkin lymphoma is about 10% of the overall population. So this number is slightly different in Singapore. I don't have a picture here, but the T cell population is slightly higher in the East Asian context. That also includes Singapore. So how do we diagnose lymphoma? So a lot of times we need a scan, right? We need a CT scan or a PET-CT scan to delineate where are the lymph nodes. And following that, we need to have a biopsy. So we can't diagnose lymphoma on the scan. So we need a biopsy on the lymph node or a specific involved organ. Last one, sometimes we do a bone marrow biopsy to both either diagnose or doing as a part of the staging process. So lymphoma is slightly different than the rest of the cancer that you're familiar with, including your solid tumor, or the colon cancer, lung cancer. So in lymphoma, the staging goes by scan and bone marrow biopsy. Limited stage is what we call stage 1 and stage 2. And stage 3 is when the lymphoma has crossed to the other side of the diaphragm. So, diaphragm is these organs separated, our lung and our abdomen. So stage 4 is when the lymphoma has gone beyond the lymph node. So no, they are not just staying in the lymph node, they have involved other organs like a skin, like a bone marrow. Then you call it a stage 4 disease. So I'd like to start off with low-grade lymphoma. So low-grade lymphoma, as what they are called, they are slow-growing. So some of them might have been in the body for months and years without realize. Some might stay silent in a low disease burden, and they do not cause any harm. In those cases, depends on the disease status as well as your symptoms. We could keep a close eyes and continue to monitor without need to treat, and weighing on the risk and benefit of the treatment. In small proportion of cases, the tumor itself or the lymphoma itself doesn't cause a problem, but when they are releasing some abnormal protein, abnormal antibody, and when those antibody affecting your body function, then we need to initiate treatment either. So high-grade lymphoma always grow rapidly and behave aggressively and always need to be treated immediately, because it could cause, it could be life-threatening if left untreated. So sometimes some of the high-grade lymphoma affecting the crucial site, like your brain, your eye, your spinal cord, your intestine. So it can result in paralysis, visual loss, as well as internal bleeding. So in this case, immediate disease control is very important. So concept of treatment. So now we realize that the treatment is actually more like a joint decision. So there are several factors that we will need to take into consideration. That include patient disease factor, because is it a low-grade lymphoma or is it a high-grade lymphoma? Different disease tempo, different pace of progression will determine how aggressive you want to go with. The second factor is actually fitness factor. I can't compare a 30 years old young man compared to an 85 years old elderly lady and using the same treatment for both of them. So because patient fitness is important. The last part is actually drug efficacy and toxicity. In the ideal world, we want some drug which has 100% efficacy and zero toxicity, but that's not possible. So every single medication has come with their efficacy and toxicity profile. So I'd like to introduce a few concepts of treatment in the lymphoma world, okay? So the first is chemotherapy. I guess many of you here are very familiar with chemotherapy. Either one of the family members or friends or relatives have undergone chemotherapy in the past. So chemotherapy has a long track record with non-toxicity profile. It can be oral, it can be intravenous, and it kills the lymphoma cells, but at the same time, it also affects the normal cells. So because some of the normal cells, they're also rapidly growing, including your hair follicles, your mouth mucosa. So those areas can get affected. So hair loss, mouth ulcer, infection, anemia, and low platelet are the common side effects when someone is undergoing chemotherapy. But the good side is actually you will usually work rapidly and for quick disease control. Example, I have a patient with a 10 cm mass compressing the abdomen. What I like to do, if the patient is fit, I'll go with chemotherapy first line because it's very quick disease control. Yeah, like I mentioned, it can be intravenous or oral. But majority are intravenous. And most of the time, we don't give chemotherapy for a long duration. So usually it's a limited duration, about 4 to 6 months, finish one cycle, finish about 4 to 6 cycles, and then we stop. Not very costly because most of the drugs are long non-drugs. So some of the chemo regime that we mentioned here, like CHOP, ICE, DHAP, bendamustine, those are the common regime that we use. So the regime comes in a name like this because they consist of 3-4 drugs or different drugs. Like CHOP, CHOP actually consists of 4 drugs, and ICE consists of 3 drugs. That's so the same thing going on. So effects of chemotherapy. Like I mentioned earlier on, the hair loss, the mouth sore, nausea, vomiting, constipation, or diarrhea, and sometimes affecting the nerve, causing neuropathy. Usually manifested as like a tingling sensation at the fingertips or numbness. A weakened immune system that can result in infection. The second one that has also a very long track record is actually radiotherapy. So, however, radiotherapy is only suitable for localized lymphoma. Example, the patient has a lymphoma in the gastric, nowhere else. Yes, this patient can be suitable for radiotherapy. So it improved the local disease control. At the same, in some of the cases, we also do it after the chemotherapy to improve the local disease control. The side effects are usually local effect, including like skin burning, mucosal ulcer, in rare cases, secondary cancer. So secondary cancer can be like breast cancer if the radiotherapy is shining on the chest. Yeah, these are the cases that we previously encountered. The third one is called immunotherapy. So immunotherapy is using antibody or using your own body immune system to attack the lymphoma. So it is rather specific. They kill the lymphoma cells by identifying a specific marker on the cell, and so it resulted in certain specific side effects, but there's less systemic toxicity. So a lot of times we combine them together with the chemotherapy and it works better. Immunotherapy sometimes takes a longer time to have a better disease control. So you may, your doctor may prescribe it for like 6 months, a year or two. And because they are more, newer drugs, so the cost is slightly higher. So the common names here, some of you might heard before, is called rituximab, brentuximab. Recently, we also have polatuzumab, pembrolizumab. So example, rituximab is been in the market about 30 years, 20 to 30 years. It's targeting this marker called CD20 on the surface of the B cell. So it's used in a lot of B cell lymphoma. Okay, and usually we combine together with the chemo. So like I mentioned just now, there's a CHOP regime for chemotherapy. So we combine rituximab to the CHOP and it becomes R-CHOP. So that commonly used in some of the aggressive B cell lymphoma. So another, just a pictorial illustration. So you can see the monoclonal antibody bind to the cell, and because they have a specific antigen on the cells that can be recognized, and subsequently they signal and attract other cells of the immune system come and attack the lymphoma cells. Next one is called targeted therapy. So this is a bit new, but has been there for maybe the last 5 to 10 years. So it targets on the survival pathway of the lymphoma cells and disrupt it and makes the cell die. Because it's quite specific, so it's fewer systemic side effects, and some of them are actually oral options. So our patient can just continue to take the tablets at home and can avoid hospitalization. So in our experience, it worked better in a certain low-grade lymphoma, example like chronic lymphocytic leukemia. So the main treatment nowadays are actually oral targeted therapy. However, it can be used in general. Sometimes you use it for long term because as you stop it, the disease can come back. It's more like a controller rather than a curable intent. So new drugs always come with slightly more higher costs, and the names here are listed down. Could be those drugs like ibrutinib, acalabrutinib, and venetoclax. All these 3 drugs are all for CLL. They're also used in some other low-grade lymphoma. So this is just an example of this ibrutinib, which targeting on the Bruton tyrosine kinase pathway. So this CLL cell or those B cell actually rely on this pathway to continue to survive and replicating. So what they do is this ibrutinib block the pathway, inhibit these enzymes, and hence they can stop the cell from replicating, and later on the cell will die off. Next one, just touch a little bit on this is bone marrow stem cell transplant. So there are two types of stem cell transplant. One is autologous, using your own stem cell, and allogenic, which is using another person stem cells. Okay, and usually we find from a specific match donor, like your siblings, or half match donors like your children or your parents, or another person who is not related to you but they have matched with you. So autologous transplant is by your own stem cells. So we need to pre-collect your own stem cells, followed by giving you a high-dose chemo and re-infuse the stem cell. Allogeneic transplant is work differently. We just collect a stem cell from the donor, infuse into you, and the cell will restore the blood system, as well as act as immune cells against the lymphoma. So this is what we call graft versus lymphoma effect. This bone marrow stem cell transplant comes with high risks, and it is actually also a systemic treatment, so it can affect every single, all part of your body. It is only used for specific indication in certain subtype of the lymphoma, and a lot of times in a relapse setting. Long track record, not too expensive, but has to be individualized. Certain fitness level is required before the patient can undergo bone marrow stem cell transplant. So this is just quick one. So we collect the stem cell first. This is using the patient's own stem cell. Collect the stem cell, we do some processing, we store it, and then we give you chemotherapy, then we infuse back stem cell to you. So bone marrow transplant is not like tumor, like solid organ transplant. You need to undergo a surgery, cut out your abdomen, put in a new kidney, etc. The bone marrow transplant we use all by intravenous. Cell therapy. All right, so this is a new concept of treatment. Is using existing cells from the patients or from the others, and after that we extract it and then we modify it in the lab so that it can recognize and kill the lymphoma cells. So one of the famous name here is called a chimeric antigen receptor T cell. So it's using a T cell but manufactured and modify it so the T cell can recognize certain marker on the surface of the lymphoma. So this is very disease and patient specific. One product can only be used for one patient. So, and currently it's only a few diseases that have been approved for the use. Currently is the diffuse large B-cell lymphoma and the B acute lymphoblastic lymphoma that is being approved to be used. So I mentioned it's very individualized. So I take out your cell, I go and modify it, and this cell can only use for you. I can't use it for other patients. So FDA has approved the first party products about 5 years ago. And then recently, SGH, maybe about 2 or 3 years ago, we started to have our first case for the commercial CAR-T products called Kymriah. Currently, there's also ongoing research and study going on to treat other types of hematological or solid cancer. It's very expensive, as you can see. However, the cost is just one-off. It's not like those continuous treatment. So that's how you see the cost effectiveness. Yeah, several paper has talked about that. I'm not going to elaborate too much. And last is concept of clinical trial. So eventually, although we have all the good drugs, all the good targeted treatment and immunotherapy, but there are still patients who not respond to one of the treatment. So or all the treatment they are not responding to. So there are many drugs out there are all under investigation. Some at the early stage of development, they have been around, but some of them have been around for reasonable good efficacy and less toxicity. Of course, if you compare to the previous treatment, there are short track record. We need to monitor the side effects very closely. But this is considered a new drug, so they might potentially benefit certain subgroup of patients, especially those in the relapse cases and no other options of treatment, and when the conventional treatment is no longer working. So we might recommend or might suggest the patient go to a clinical trials. And because of the clinical trials, the drug itself is free, sometimes even including the blood test, the scan, everything is covered by the drug company. Yeah. So last thing is we are still in the COVID-19 era, and we are trying to learn the relationship between the COVID-19 and lymphoma. And so far, there's no clear link. Of course, it may affect certain patients in terms of their disease, treatment timing, and the choices. Example, defer the treatment until completion of vaccination if disease allows us to do so. So we also realize that the lymphoma treatment sometimes will reduce your immunity to fight the COVID-19, and as well as the efficacy of the vaccine is lower in this kind of patients. However, that's why we always recommend 4 doses of the vaccination for better protection. And nowadays, we also have some new drugs to help patients to fight the COVID-19, including the antibody, including some antiviral. So yeah, so it comes down to a risk-benefit ratio, but again, I think we will recommend majority of patients to go for vaccination. So last, lymphoma and its journey is a marathon. We're trying to eliminate the disease and remain in complete remission. That's why I call 5 years. You are called cure if you don't have a disease coming back. But if it's not realistic, then try to live with them peacefully, especially in low-grade lymphoma setting. It is actually an exciting time because there are a lot of rapid evolving new treatment that might benefit some of our patients. One size doesn't fit all. We have to be individualize the patient's treatment, and sometimes we call it personalized treatment care plan. Thank you. Happy to take any questions later on. Thank you.
Thank you, Lawrence, for that excellent talk. We will move on to the next section. We will save all the questions near to the end. So the next speaker is Dr. Melinda Tan, an associate consultant at the Department of Hematology at Singapore General Hospital. Today, she will be talking about myeloma and what a patient journey is from beginning to end. Melinda?
Hi, everyone. Thanks, Tertius, for the introduction. So today, my topic will be on multiple myeloma, and I'll talk about what a patient journeys as he gets diagnosed and the treatment options available. So first, an introduction as to what is multiple myeloma. We've heard from Lawrence that lymphoma is a blood cancer that is also to do with the white blood cells. So similarly, multiple myeloma is from a type of white blood cells called the plasma cells. And due to the excessive multiplication of this, it becomes what we call blood cancer. It is the second most common type of blood cancer in Singapore. And about 100 to 120 patients get diagnosed with this a year. So we also know that the incidence of multiple myeloma is increasing. And this is possibly because people are living older. So as they get cured from other diseases, we know that multiple myeloma increases with age, so therefore perhaps more people are getting it because of that. And secondly, we have better ways of detecting multiple myeloma as well. So once again, just trying to illustrate what multiple myeloma is. So firstly, we have this on the top, which shows a normal bone marrow. So in a normal bone marrow, we do have plasma cells. We did say just now that plasma cells are the culprit in multiple myeloma. So these are normal plasma cells, and actually they have a very important function, which is produce normal antibodies. As most would know, these antibodies are there to fight infections. So in a normal bone marrow, these are there producing antibodies, fighting infections. However, in multiple myeloma, these plasma cells are abnormal. So they grow, they multiply, and then they also make antibodies which are abnormal. And these antibodies do not protect us from infection, but rather they affect other organs and cause problems. The areas they affect mostly include bones, kidneys, and also the blood, which I'll illustrate and talk about in the next few slides. So multiple myeloma has no cure, unfortunately, but with newer agents and new treatment options, there is a possibility for long-term remission. And when they are in this phase of prolonged remission, patients do not actually have signs or symptoms of multiple myeloma. And in fact, many of our patients live a normal life. They can go back to work and they have a reasonable quality of life. So bring me to the next point, that a lot of these treatments are long-term and they are aimed at trying to help our patients live for as long as possible, but at the same time, we also want to balance their quality of life such that we enable them to still do the things they want to do. If they are younger, go back to work. And multiple myeloma is more common in people over the age of 55, and it does increase with age. So over the age of 80 years, up to about 5% of patients have myeloma, and the median age of diagnosis is between 65 and 74. So what are the symptoms that we will look out for or make us suspect someone having multiple myeloma? Bone pain is common. It presents in up to 70% of patients with multiple myeloma, and they affect particularly the backbone and the ribs. Anemia or low red blood cell count can cause symptoms such as tiredness. They may feel short of breath, especially as they walk longer, or they just start doing their exercises and notice something's different from their baseline. Bone fractures with minimal or no trauma, and by that we mean simple things like lifting up the usual boxes, reaching up their hands to do exercises, and they fracture without having fallen or anything like that. So these are also red flag symptoms. They have recurrence of frequent infections, kidney damage, unexplained weight loss. And multiple myeloma, because of a large proportion have some sort of bone disease, and because of that, many do have high calcium levels. And as a result, some people may have symptoms of high calcium levels, which may increase thirst, cause constipation, some even coming confused. So while these are quite non-specific, some of the symptoms can be, pretty much anything. We usually need to further investigate in order to confirm that a patient does have multiple myeloma. And first, we usually start off with, of course, seeing the patient in clinic, taking a history, asking them about the symptoms they've had, how long it's been there for. After which, then we will start running some blood tests, and this would include things like the blood counts. We will see whether their hemoglobin levels are low, and also at the same time look at the kidney function. We will also run the amount of antibody levels they have in their blood. So once we have a suspicion of multiple myeloma, once all the blood tests comes back, and we want to confirm the diagnosis, we usually do a bone marrow biopsy in order to find those abnormal plasma cells that we saw in the earlier diagram. and to look and examine whether these are actually the abnormal blood cells, how many are there, to confirm that this is indeed multiple myeloma. The next, we will also usually do imaging, and this means things like PET CT scans to look for areas which are involved by multiple myeloma, because often the bones are involved and it might not be just one place. So then we'll look out for where else and where other areas are involved. So the journey is quite long, as you can imagine, and therefore we often have a very long-term relationship with our patients because they are often on treatment long-term. We start off first with this phase where they might come in asymptomatic, and usually these are the patients that may present with some other problem, and then someone did some blood tests and then noticed there were some abnormalities. But really, no, they haven't, there's no need for treatment at this earlier stage. We will often watch first. Some patients, or a majority of patients we see in SGH, come in with symptoms, which is what we explained earlier, like bone fractures, bone pain, and this is when they get diagnosed with active myeloma that requires treatment. So we will then treat them, and most will respond. They go into remission. However, because multiple myeloma has no cure, it relapses, and then we treat it. It goes back into remission, and it does have this sort of relapsing course until, in some cases where they relapse multiple times, and for various reasons, they might not respond so well to treatment. So we know now that we have a lot of new medications, new drugs, new therapies, and all this is aimed at trying to get the remission as deep as possible, especially in the first remission. So in order to control disease, so what I have here on the left side is how good the disease control is. I'm just illustrating. Undetectable MRD refers to undetectable minimal residual disease, or we cannot find any disease in the patient. And with that, we see that, look, they have a very long curve at the bottom, which doesn't come back up. So these patients actually do very, very well. They have long-term disease control, and the time to relapse is long, some don't even. So really, we think that, this is what we all aim to get our patients towards at the end of the day with all the treatment that we give them. So moving on then to the topic of treatment. Treatment in multiple myeloma is multi-pronged. So we can see that actually multiple myeloma does affect many areas, the bones, the kidneys, the blood counts. And the treatment that we offer includes, at this point in time, chemotherapy is our first line standard of care. That includes also steroids within the treatment regimen. I think Dr. Lawrence did allude to newer agents for lymphoma. Similarly, multiple myeloma, we do have newer targeted cellular therapy as well. But I think one really big sort of prong that we really have, we often overlook, is this supportive care, where patients get, besides chemotherapy for the treatment of the underlying myeloma, they also need certain specific care for their bones, for example, so bone health. We give them extra supportive medications to strengthen bones. Other things like pain control, because if they have pain, they can't move, and then it affects their mobility. Apart from that, also that we spoke about long-term treatment, so patients do come to and fro, and all these things need caregiver support because it is a long journey. So just an overview, broad overview of the treatment paradigm for newly diagnosed multiple myeloma. We did say that they get chemotherapy, so this is the initial chemotherapy. And in patients who are slightly younger or fit, we do get them to a transplant. And this is similar to what Lawrence did mention earlier about stem cell transplant via infusion. So this is what they do go through. After that, they get maintenance therapy, and then if they relapse, we would then treat them differently. In patients who are elderly, who are not fit, or they choose not to undergo a transplant, then they do get long-term treatment and maintenance therapy. So just put up this slide to show that we do have multiple agents that are used in multiple myeloma. And this slide is just to illustrate that some of these are actually oral medications, some of these are injections, but a lot of multiple myeloma treatment options are given outpatient because we do recognize that these are long-term patients on treatment, and therefore some of these options do allow them to be flexible. And for example, if they need to go to work or reduce treatment time in hospital as well. So, newer therapies in multiple myeloma, I think some of it has been covered by Lawrence, which brings me nicely into introducing a few things. So I think many in the audience will probably have heard about CAR T-cell therapy because that is a new treatment option that's available. It is also available for multiple myeloma, only in the refractory setting or the relapse. That means they have gone through at least 3 different treatments prior. There are also some antibodies available and other newer chemotherapy agents. So I think this is very similar to a slide put up earlier where we saw that we are using antibodies or targeted immunotherapy to treat multiple myeloma. So in multiple myeloma cells do express a specific signal on their cell surface, and this drug is an antibody which binds to the signal on the cancer cells. It then induces downstream signals to the cells, and the cells get killed off by their own body. So there are a few mechanisms in which they do that. For example, using the natural killer cells that occur in the body, using antibodies that result in cell death, using things like macrophages, which eats up the multiple myeloma cells. So all these are mediated by the monoclonal antibodies. And in multiple myeloma, we have this, for example, daratumumab is one example of this monoclonal antibody. So here's a very quick illustration of what a CAR T-cell therapy is like. In this particular therapy, we take out some white blood cells from the patient via the veins, and these are the T cells. CAR Ts are basically genetically modified T cells, which have engineered signal on their surface, which recognizes cancer cells. After that, these T cells are grown and expanded because we do need an army of them. And then they are put back into the patient's body, and these T cells will then fight the cancers in the patient's body. So, well, it does sound like a very nice sort of therapy, but why is it not for everybody? It is because it is a complicated setup and manufacturing that is involved. There are delays, there are toxicities which can be life-threatening. So it's not for everyone. It also depends on patients' fitness and tolerability. And the disease still relapses, unlike some other blood cancers that we use CAR T-cell therapies in. And once again, the long-term outcomes and toxicities are also not available. So, it's kind of like, we are still in the phase of using them and then observing what happens to these patients. So lastly, clinical trials are also available in our institution, and we often offer it to patients who have an unmet need, for example, the relapse patients for which all the other therapies do not work. Or relapse patients who have, who needs new drugs. Even the frontline setting, there are some newer drugs available that are on clinical trials that we have opportunities to use here. So I'll then move on into a somewhat overlooked area in multiple myeloma or generally in the treatment of cancer, which is physical activity. So our patient comes to see us, get diagnosed with multiple myeloma, they get lots of medications, chemotherapy, and more drugs. Every time they come and see us, we just add on to the pile of pills they eat. But very often we overlook this whole side of physical activity. And actually, there has been increasing evidence in the literature that actually suggests that physical activity is as effective as therapy, like drugs, in both during and after cancer treatment. So we really should, advise our patients, and also if you have family members, to avoid inactivity or be more active, really. And it's been said that moderate intensity aerobic activity for at least 30 minutes, at least 3 times per week, and resistance training at least 2 times per week, helps improve fatigue. So they improve the muscle strength, the aerobic fitness, the overall quality of life. It reduces anxiety and helps with sleep as well, and self-esteem in cancer patients. So these are actually guidelines for general cancer patients, but we are cognizant and we realize that in multiple myeloma, some of our patients are a bit different. Why so? Because they have things like bone pain, back pain, because they might have come in with a fracture that was recently just opt on, so they can't do the same kind of activity as someone else who didn't have that fracture. They might have a lot of bone pain as well. And they might have low blood counts, like low red blood cell counts, that might make them, more breathless, for example, when they do certain activities. So in this cohort of patients, we actually have to be more personalized, and we give them, we sort of refer them to our either rehabilitation colleagues or physiotherapists, and give them an exercise program that actually targets what they can do and their needs. But I guess the bottom line is that they should be actively involved in these exercises. And multiple studies have looked at the effects of exercise in multiple myeloma, and it's been shown to actually reduce fatigue. It has shown to improve blood counts, better mood and sleep, and an overall improvement in their quality of life. The next thing is body weight management. We've also realized that with bone pain, bone fractures, they don't move very much. They are muscle waste, and then they also get deconditioned, so they gain weight. We use a lot of steroids in the treatment of multiple myeloma. So they have increased appetite, once again gain weight, their blood sugar and cholesterol levels increase, or they don't do so well with their controls. So really what we would advise in this population of patients is that we would actually reduce the steroid doses, but besides that, physical activity has been shown to improve all these as well. So lastly, talking about sleep in multiple myeloma, once again, a very common complaint in cancer patients. And the result of sleep deprivation can be quite there's a lot of downstream effects, which we might not directly attribute to sleep deprivation, such as increased risk of infection, cardiovascular disease, cognitive impairment, and especially the mood-related disorders. A lot of people come in with low mood, they are tired, and they cannot tolerate treatment as well because of that. Once again, sleep deprivation also leads to obesity because they are inactive, and they gain weight. So really, other things like bone pain and the medications such as steroids also contribute to them having lack of sleep, because steroids do cause insomnia. And they might have low mood due to the diagnosis, due to having come back very often for treatment. The other thing is they might have neuropathy, and that is nerve damage, like numbness, some burning sensation, which are very often worse at night. And this does sort of impact their sleep and keeps them up at night. And kidney failure is also a risk factor for poor sleep. So in these subset of patients, we often advise good sleep hygiene. I think it's simple things like lifestyle changes, but does go a long way. For example, limiting daytime naps and exercises, maintaining a constant sleep schedule, avoiding caffeine, alcohol, food and drinks with high sugar content that will keep them up at night. such that they can keep to a regular, consistent or early sleep schedule. They reduce the noise and the light in the bedroom. We, as doctors, would actively sort of tail down or reduce the steroid doses if they really have a problem, and at the end of the day, hopefully can tail it off. Relaxation, gentle music, massages are some things that patients tell us works, and sleep-inducing medications many people request for because it works, but it is only helpful in the short term, because in the longer term, it is harmful as they can be addictive. So last, I'll touch on nutrition. So the American Cancer Society does recommend a healthy diet. I think this is like, oh, of course, right? But it is actually more difficult to reinforce because a lot of patients have poor appetite. So trying to get them to take a good healthy diet is also challenging. So we often have to sort of get our dietitians on board as well, and then see how we can come to a middle point and hopefully improve it over time. So they've advised for at least 2 to 3 cups of vegetables and 2 cups of fruits each day. Whole grains are preferred to refined grains, and especially processed red meat consumption should be limited. So we encourage controlling caloric intake and, of course, once again, engaging in physical activity. So nutritional deficiencies are very common in multiple myeloma, such as vitamin D, vitamin B12, vitamin folate, as a result of poor nutrition. So we would also top this up either by reinforcing their diet or by giving supplementation. So in conclusion, there are newer therapies for multiple myeloma that are being discovered and approved. So these are all promising and improves efficacy, and also, hopefully they have manageable toxicities. Exercise, nutrition, and sleep have been often overlooked, but they do have a multitude of benefits in improving symptoms, and it works hand in hand with giving the most effective treatment we can for multiple myeloma. That's all I have. Thank you, and I'll be happy to take questions at the end of the session.
Thank you, Dr. Melinda. Again, we will save our questions more till the end. In the meantime, feel free to type into the Q&A your questions. Our next speaker will be Dr. Nurul Ida. She's a consultant at the Department of Hematology, Singapore General Hospital, and she will be talking about leukemias. In particular, her title is Leukemia a Death Sentence in 2020? Over to you, Dr. Ida.
Good morning, everyone. Thank you, Tertius, for the kind introduction, and thank you to the rest of the audience for joining us today in this wet Saturday morning. So today we'll have a look at some advances that have been made in the 2020s. I think there'll be some overlap with what Melinda and Lauren has mentioned in the past few slides. So what is leukemia? It's a combination of the Greek words of leukos, which means white, and ama, which means blood. So it's a cancer of the white blood cell. One of the first people that have introduced this term leukemia is this clever German doctor called Rudolf Virchow, where in 1845, when he was a very young doctor, only 24 years old, he was treating a middle-aged female with enlarged spleen and liver and lymph nodes. And unfortunately, she died, and he did a post-mortem and found that the blood vessels were full of white-colored cells, which is very different from what he usually sees in healthy people. So what happens in leukemia is that there are too many of these abnormal cells or white cells in the bone marrow, but too few of the normal cells in the blood. So we often use the word bone marrow for our blood cancer patients, and they are a factory of our blood cells. Where we can find it in kids, they can usually be found in almost all our bones, But as we grow older and become adults, the red marrow, or where the bone marrow producing blood cells are mainly limited to the fat bones, which are our hip bones and sternum. So what happens in this bone marrow is that, as you can see, it's a very limited space, but that's where baby cells or the hematopoietic stem cells are produced. And then they start to mature into adult functioning cells, which are then released into the blood. And these are the cells that are able to function things like carrying oxygen, fighting infections, and stopping bleed. What happens in leukemia is that one of our blood cells, like maybe one of the white cells, are proliferating very, very rapidly. And because the bone marrow itself is a very narrow space, they occupy the space so that the rest of the normal cells, like the red blood cells and the platelets, could not grow. If you look under the microscope, what you see in a normal healthy person, there are a healthy mix of population of cells. So on the background, you see these red color cells, which are the red blood cells. And then you can see a few of the white cells here, which are there to fight infections. And if you really look hard at the background, you see all these tiny spots, which are platelets, which are there to stop bleeding. But in the leukemia patient, if you look under the microscope, what you see instead is just a domination of one population of cells, which are the white cells. And you can tell that they look very different from the healthy white cells in a normal person. They are very large, they only have like one nucleus. And because they have so many of them, the other normal cells, which are the red cells, and the platelets are very much depleted. So how can you tell if you have leukemia? And unfortunately, for many patients, the symptoms are often very subtle until they suddenly become more life-threatening. And in fact, we do see a lot of patients who just incidentally did a blood test, either for routine testing in the polyclinic or part of their employment checkup, and found very abnormal fluid blood counts. But some of the symptoms that may present are related to the low counts or low normal counts that they have. So when they do have low red blood cells, they have fatigue, breathlessness, and pallor. And the reason is because red cells, their main function is to deliver oxygen to the body. If they have lack of white blood cells or normal functioning white cells, they have recurrent fevers and infections, and the severity may be quite bad. They can end up being fatal. If they have lack of platelets, they end up with easy bleeding. So they have things like large bruises, spontaneous bruises, petechiae, which are like tiny red spots, mostly on the limbs. And they have prolonged bleeding from like even simple things like brushing their teeth and a nosebleed. As you can imagine, that a lot of the symptoms are pretty vague, and rest assured that even though you have things like fatigue, many of us do not have leukemia. So when you do see a doctor with these kind of symptoms, the doctors do extra things that may lead them to suspect leukemia. So on physical examination, like Lawrence had mentioned, some patients may have swollen lymph nodes. They may have enlarged spleen. They look very pale, and they may have multiple bruises or petechiae on their body. If they do find this and a suspicion by the reviewing doctor is pretty high, they may proceed with doing a fluid blood count, which is a blood test. And they usually tend to see a lot of these abnormal cells, which are called blasts. The white cells may be very, very high without any signs of infection, or the other normal cells can be very, very low without any clear cause. If there is any suspicion, then these doctors, which are usually in the primary care setting, will refer these patients to us, the hematologists in a tertiary care center. And if our suspicion is also confirmed, we do want to proceed with doing what we call a bone marrow biopsy. It is a bedside procedure. It can be done without giving general anesthesia. So what the doctors would do is they would give some local anesthesia over the hip bone, and they will put in a slightly bigger needle to extract the serum, the aspirate, and probably brought in some sample to get a bone from the area. So there are many types of leukemia. Generally, we divide them into the timeline that they have progressed, as well as the lineage of the white cells that are affected. Acute means that the disease progresses very quickly, usually in matters of weeks. And chronic tends to progress more slowly, sometimes even in matters of months and years. So if you have acute myeloid leukemia, the acute ones can be divided into acute myeloid leukemia and acute lymphoblastic leukemia. And the chronic ones are mostly divided into chronic myeloid leukemia and chronic lymphocytic leukemia. I think Dr. Lawrence mentioned briefly about CLL in his previous presentation, so I won't be touching on that. How do people get leukemia? A lot of times the cause is unknown, but for those few patients that we can elicit a cause, these are among the common ones that we normally find. Things like previous exposure to chemotherapy or radiotherapy. As one of the questions mentioned before, that if you do have chemotherapy for, say, like a lymphoma 10 years before, or breast cancer 10 years before, there is a chance that later on, those chemotherapies that you get to treat that cancer initially will in the end turn out to lead you to have a bone marrow failure and some other leukemias in the future. If you do have underlying blood disorder, for example, myelodysplastic syndrome, these are what we know as precursors to leukemias. So doctors have to monitor them closely to make sure they don't progress to leukemia. If there's any occupational exposure like benzene and formaldehyde, I think what's more increasingly identified now is inherited genes that can lead to a higher risk of leukemia. What I normally get asked from patients when they first diagnosed is, how can the leukemia be staged, or what stage am I? Am I stage 1, stage 4? Unfortunately, we don't stage cancer or leukemia like solid cancers. For the simple reason that leukemia is a cancer of the blood, and the blood goes everywhere in the body. So by definition, everybody will be stage 4 by diagnosis. But there are a few ways that we want to stratify patients into a good and adverse risk using multiple parameters, mostly dependent on genetic mutations. And this course would tell doctors how the chance of survival would be, what are the chances of response to specific therapy, and the risk of progression to acute leukemia if, to begin with, they have like a chronic myeloid neoplasm instead. This is a busy slide. It's not meant for you to know exactly what the mutations are, but this slide shows the various mutations that are increasingly be identified. And these are not just the end of it. In fact, like every time there's a new journal coming out, there's often reports of new mutations identified that could have caused leukemia or associated with certain outcome based on certain therapies. So on the left here are the mutations that we are now routinely screening and routinely identifying in our patients with acute myeloid leukemia. And on the right are common mutations that we see in patients with acute lymphoblastic leukemia. So you can see that it's a lot, and eventually people are starting to realize that these leukemias are not homogeneous. There's a lot of variety even within a disease entity that could predict therapy resistance or a response. And eventually, hopefully, by identifying all these subclassification, we develop therapies that could be targeted and hence ensure a higher chance of success. Someone in the chat group also asked about gene mutations that could have led to familial hematological cancers. I think this is still a fairly new field. And as we speak, there are many new mutations that are identified that could have been a cause for blood cancers. But unfortunately, a lot of times it's not very clear, because cancers develop not just based on genes, but also there's a lot of complex interaction with environmental factors. So as we are identify more and more of these mutations, and gene testing be a routine part of our scoring investigation for patients with leukemia, we'll see more of these coming up to play. But for now, we don't quite know how to act when we have, like, say, a patient who have known risk factors for familial cancers and family being screened, and they found to have certain mutations that could expose them to high risk of leukemia. So what do we do with those with just a carrier instead of being affected by the cancers itself? So how do we treat leukemia? A lot of times it's a complex decision. And as Lawrence and Melinda mentioned before, treatment for blood cancers are usually very prolonged. They involve combination of multiple modes of therapy. They may be months and years of treatment. And the side effects of these therapies are significant. And one of course, people might, when we start chemotherapy, there's always a chance that they may die from chemo rather than the cancer itself. And hence, when we see a patient, there's always this trying to find the right balance between the chance of long-term response with chemo and the risk of complications that happen with the chemotherapy itself. And this is probably more important in the past, and hopefully will get less and less so in the future, because in the past, we often associate intensive chemo, or very, very strong chemotherapy, with a longer chance of success. So if you want to treat someone very well, we have to make them very, very sick before they get better. I think nowadays, with identification of better therapies that are more targeted with better side effect profile, maybe the balance will tip more towards what is the chance of response to whatever treatment you have available, rather than the complications that ensue from the treatment. So this is how people tend to imagine when someone has leukemia and has chemotherapy. Very, very malnourished patients, balding, and often very severe nausea and vomiting. But rest assured that I think nowadays, a lot of the leukemia therapies are getting more tolerable. And we have seen even elderly patients able to tolerate very successful therapies and leading almost a normal quality of life. So I have like 70-year-olds acute myeloid leukemia who in the past tend to be very, very debilitating, and they tend to be in hospital for months before they get better, if they do get better. But nowadays, I have 70-year-olds who, in the second month of their diagnosis and therapy, they're already asking me to go back to work, or they're already asking, or rather already cycling daily to get their morning coffee from their kopitiam downstairs. So I think it's a very good signal that, with new therapies, we probably see less indeed of these and more of the ones on the right. As myeloma and lymphoma, the leukemia therapies are also multiple, and there could be a combination of these modalities and not just one. So we have the standard chemotherapy, which tends to be the upfront therapy of choice. They can be given via intravenous, which means into the blood, subcutaneous, which means under the skin, or oral therapy. Sometimes, or most of the time for our leukemia therapies, they are given in combination. Now, as I mentioned, we have more and more targeted therapies, which either target the surface marker on the cancer cells or the mutation that are specific for cancer cells. We have immunotherapy, what I mentioned later, or what has been mentioned previously, the CAR T cells, where we train our immune system to fight the cancer cells. Radiation therapy, which probably not so much common therapy in leukemias, but we do still give it for occasional acute lymphoblastic leukemia to protect the brain from spread of the cancer cells. And sometimes we do give it before stem cell therapy to condition the body before they get the stem cells. And of course, stem cell transplant is still a major component of our acute leukemia therapies, because a lot of the time, these are probably the only chance of long-term survival. Now we go through some of the new therapies and new advances that have been made in the field of leukemia. So one of the first few groundbreaking therapies in the field of not just blood cancer, but cancers in general, is the targeted therapy. And that has been first discovered by the tyrosine kinase inhibitor called imatinib. It's a groundbreaking drug for CML and also for other cancers, because it changes the paradigm of how we view cancer treatment. It is an oral therapy which can be taken at home, and most of the time it's very well tolerated. They can even give it to very, very elderly patients. In the past, we know that CML can be fatal. Beyond, after a few years, they can progress to acute leukemia, and after that, their outcome is very, very poor. Very few patients tend to live beyond 10 years. But now this transplant is rarely needed for CML patients. And this graph nicely illustrates the success that we see with CML. So the first two lines here are the outcomes of CML that we see now with this oral TKI. And this is the survival that we see in the past And you can see that nowadays, many patients tend to live beyond the 10 years mark. And it's also interesting to know that one type of leukemia can now be potentially cured without the use of any chemotherapy. So that has been discovered by this Chinese physician, Dr. Wang Zhenyi, where due to the high cost of available chemotherapies to treat APML, which used to be a very feared leukemia, because if patients come in with this, they can bleed very, very quickly and die very, very quickly. So in China, at that time, the cost of treatment for APML is very high. And driven by this economic need, he wanted to explore the therapies that are more easily available in China, and discovered this drug, arsenate trioxide and ATRA. And now with combination of these two therapies, our cure rate now approaches 80%. Not too long ago, the outcome of leukemia in children is very, very poor. As you can see in this graph, the chance that a child with leukemia surviving beyond 10 years is less than 10%. But as the years progress, with multiple works from multiple centers using a combination of therapies, the survival keeps getting better. And nowadays, what's more interesting is that the therapy for ALL in children is not just targeting survival, but they're also trying to find different combinations that make the treatment more tolerable and can be given, even in the outpatient setting. And of course, I think a lot of us are aware about this very lucky British boy that was given CAR T-cell therapy for his multiply relapsed acute lymphoblastic leukemia. And at the 1 year mark, this was published sometime last year. He was still alive and cancer-free. And CAR T is now available in Singapore. SGH is one of the biggest centers to do CAR T cells as well, either part of commercial CAR T, but also as a clinical trial offering. So a lot of new drugs are coming up. This is just based on acute myeloid leukemia. As you can see here, for 20 years, before 2000, there are hardly any new drugs coming up. So there was a stagnant of outcome. But beyond 2000 onwards, up to now, almost every year, there are some discovery and approval of AML therapies. And we are lucky in Singapore that many of these are available here in Singapore, and they are also listed under the cancer drug list. So cost will not be so much of a concern. But of course, challenges still remain. Treatment for these groups below remain challenging still, like the elderly patients with acute leukemia, or someone who has failed the initial therapy or the cancer relapsed after a few years. And of course, everybody's concern is that the cancer care cost is really, really high nowadays. And because a lot of times now, the chemotherapy duration can be quite prolonged, and hence it has to be considered into the cost as well. If you're looking beyond the dry facts of leukemia on the websites, there are certain books that you may want to consider reading. These are all written by practicing hematologists in the States. So especially the first two, they make excellent bedside reading. Thank you.
Thank you, Dr. Ida, for a very comprehensive talk. At this point in time, if there is no other input from our speakers, we will move on to the Q&A portion of our talk. I think that there are some questions that we have brought up for questions during this time. If you have any questions, especially for the last talk which just finished, you can continue to post your questions on the Q&A section. Right now, I'll invite the speakers to come back and answer any questions that may pop up, or answer some of the previously common questions that are asked. Shall we move on to the Q&A? I think we have some that are coming up. Okay, so the first question is, how can we visually know when to see a doctor or request for a scan? In particular, this is meant more towards Dr. Lawrence's talk about lymphoma.
Hi. So thanks for the questions. I think if you, I mean, just giving you an example, I previously showed a slide on what are the symptoms of lymphoma, but unfortunately, lymphoma is it can happen anywhere in the body. So there's no one answer for this question. So, but in general, if you're experiencing a painless lump in your body, that the common area, those are like in the neck, in the armpit, in the groin, or anywhere in the body that doesn't go away with time, I'll suggest you to see a doctor for further assessment.
All right. Shall we move on? Okay, same, also addressed to Dr. Lawrence. When you mentioned painless lumps, what spots and locations are you referring to specifically?
In lymphoma, the common areas are the neck, the inguinal, the groin region, and the axillary, the armpit region. I also forgot to mention, if you're experiencing symptoms like loss of weight, loss of appetite out of nowhere, extremely fatigue, fever and night sweats, those are also the symptoms that warranted further assessment.
Okay, this can be mentioned in multiple people. What is the difference between intravenous and oral chemotherapy? Are there any difference in the efficacy and their indications? And I think that from all three, we can even talk about a little bit of this.
Yeah, but there's no short answers to these because both intravenous and oral chemotherapy is the efficacy and indication doesn't rely on the mode of delivery. So it really depends on what types of the cancer or what type of treatment you are undergoing, then the physician will prescribe accordingly. So, but of course, oral, it will be easier to give. The patient can take it orally at home. But intravenously, you usually need to be in the hospital. So there's no, I mean, the efficacy indication doesn't rely on the mode of delivery. We also have chemotherapy delivered under the skin. So it's not neither intravenous or oral.
This one goes out to Dr. Melinda. In myeloma, what are the causes for, and why is there an excessive calcium level? Can you elaborate?
Hi, thanks for the question. So excessive calcium doesn't cause myeloma. Myeloma, one of the symptoms of myeloma is raised calcium or excessive calcium. So it's not a cause of myeloma. So if you have a lot of calcium, you eat calcium supplements, those do not cause myeloma. The reason why in multiple myeloma, when we check the blood levels, we notice that a lot of patients have increased calcium levels is because of the bones that get destroyed as a result of the cancer. So, there are many causes of calcium. So even if you find that someone's calcium is raised, number one, that doesn't equal multiple myeloma as well, because there are many other causes of raised calcium. So, although that in the correct clinical context, like if the patient has bone pains, low red blood cells, then yes, multiple myeloma would be something that we would highly suspect. But we would also, definitely have to make sure that the raised calcium is not due to other things. like parathyroid hormone disorders. So I think in summary is that excessive calcium does not cause myeloma, so taking calcium supplements and all that does not cause myeloma. But one of the signs of myeloma when we check it is that they have raised calcium levels. I will also like to touch on the previous question that Lawrence answered in regards to intravenous and oral chemotherapy. So I think someone asked the differences, and I think it is something that's very relevant to patients with multiple myeloma because a lot of the treatment is long-term ongoing and outpatient. So I think one of the obvious differences between intravenous, subcutaneous, and oral is that the time it takes for the patients to get their drugs. For intravenous and the one that's under the skin, subcutaneous, the patients have to physically come to the hospitals to get that. And many times for multiple myeloma, it is almost like a weekly or 2-weekly affair because they come for that. So because of that, it's inconvenience. Of course, there is some pain when they inject it. And also inconvenience to not just the patients, but the caregivers. We have a lot of multiple myeloma studies have shown that oral chemotherapy is a preferred option. I mean, I guess for obvious reasons that it can be administered at home. Patients and family members do not need to come to the hospital so often. So there is no difference though in the efficacy because it depends on which chemo you're using, what drugs you're using. Some of the oral chemotherapy can be equally efficacious as the intravenous ones. The toxicity profiles are also different. Doesn't mean you give intravenous, it is more toxic, and if you give oral, it's less. No. So I think it really depends on the drug of choice that you're talking about. And once again, even though most people prefer oral chemotherapy, I think there was a study which also showed that compared to efficacy, most people would favor efficacy more. So they would choose the drug with higher efficacy, whether it be intravenous or oral in multiple myeloma. So, you know, I think at the end of the day, it is your discussion or the patient's discussion, patient, family, and doctors' collaborative decision as to which one we would opt to use. You know, considering the efficacy, the toxicity, as well as the convenience of all parties involved. I think that's all.
So there are some other questions that are being filed in as we speak. One question I think is commonly asked about myeloma is there a cure to myeloma?
So at this point in time, we often say that there is no cure in multiple myeloma, but there is a new concept that is almost like a cure. And what we mean by that is that you have very, very good long-term control of the disease such that the relapse doesn't happen for years and years. So essentially the patient is cured. Although that concept is the new one because it's only the newer agents or, with many more newer therapies are we able to get patients into a state where their disease is extremely well controlled and therefore giving them that long-term outcomes.
And then in terms of another question, this person's family had cancer, leukemia in the past, as well as colon cancer, and they had passed away 30 years back. And currently, this person is in his 60s, and he was wondering whether this specific case is leukemia possibly to be inherited, or in general, is leukemia inherited? And how would you advise moving forward this person?
I think Ida is trying to type
Oh,
answer.
yeah.
Would you want to answer that?
Yeah,
live,
because
Ida?
right now we're doing it kind of live because of we didn't have enough time to publish all these questions.
Sorry, I missed it. It's the one that
So
you're typing for the leukemia
yes,
and for
I'm
lung
sorry.
cancers,
Yeah.
is it?
As
Okay,
in,
okay.
If leukemias are inherited is the question, and whether the fact that his father had leukemia as well as colon cancer in the past and passed away, whether leukemias can be inherited.
I think it's not the assessment of inherited blood cancers is still not cut in stone yet. There are a lot of things are still evolving. There are certain centers in the States, for example, they do look routinely for these inherited mutations in all what we call that the primary patient who presented with it. In this case, that your father, if any suspicion, the hematologist or oncologist would screen your father for that certain mutations. But if things like that are not done in him, what we do for the rest of the patients is that we do take a very thorough family history, and that includes things like history of cancers in 3 generations, not just cancers, but also low blood cell counts. Sometimes we look at liver or lung disorders that they have, or even neurological disorders nowadays. And then the doctor may have to examine you thoroughly to find any physical abnormality that could indicate certain types of inherited bone marrow failure that could increase risk of leukemia. And also it depends on if there is a family history, that they look at the type of family history, because this type of inherited leukemia tends to cluster around certain types of specific cancers as well. So if there is any concern, you can always discuss with a medical practitioner to see whether you need any further screening being done. Thank you.
I think there are quite a few questions that I think we still have some time. Maybe we can do a live Q&A instead. So I think there are some questions there that we might all be able to answer live. And one of them, I think that has a recurrent sort of theme is, if there are no lymph nodes and in the neck, armpit or groin, how do we know whether or not we are dealing with blood cancer or lymphoma? Maybe I'll start first, and then the rest can chip in as well. So I think firstly, it depends on whether you have other symptoms. Some of the other B symptoms would include things like night sweats, fevers. You're losing weight even though you're not controlling your diet. So those are signs that something else is going on even though you don't have lumps. Some other things that we might pick up if you see a doctor is blood counts that are a little bit low, or there might be other abnormal things that are seen on the blood counts which may then alarm the doctors to then subsequently refer you to hematology. So I think not necessarily just lumps. So for example, leukemia may be picked up on a low screening full blood count. I'm not sure what the rest have advice on, sort of screening and how does, maybe the public know when to present for, a blood cancer.
I think one of the common questions typed here is that whether we should routinely do full blood count and whether we should screen for blood cancer routinely. I don't think there is a standard guideline now to do so, because one of the things that comes with screening is that you may identify a lot of false signals. So for example, if full blood count is routinely done without any need for it, you will see a lot of abnormalities that in the end lead to a lot of other successive tests. And we don't quite know whether doing those tests and will increase the early pickup of cancers. And even if you do pick it up early, whether in the end the outcome would change. So I think unless there are more data coming up large trials to suggest that yes, doing such early screening may help to improve the outcome of cancer care or leukemia care. I think that's still a bit hard to justify.
I think that another common theme is that for screening is this concept of like tumor markers. I think that often people are doing ferritin and they're worried that their ferritin level being low, their ferritin level being high, whether that there's any indication of a blood cancer. That is also another theme that is going around for these questions. I think the resounding answer is ferritin is very non-specific and it's not used as a tumor marker or a cancer marker, and it does not imply that you have a leukemia, lymphoma, or myeloma one way or the other.
Yeah, I think to echo what Tertius has just said, so ferritin, I think someone's been asking whether what other tests should they do. I think that needs to be interpreted in the appropriate clinical context. If you do have, say, other symptoms like weight loss, fevers, and all that, yes, it needs to be worked up further. So I think maybe the first step is why was it done in the first place? And if you do have concerns, the first step would be probably to go back to the medical doctor or the medical professional who did it. And then it will be interpreted so that you can interpret it in the correct context. So things like, for example, autoimmune diseases sometimes can cause raised ferritin. So I think there were some comments about things like SLE. So if in those contexts, yes, sometimes when you have flares of rheumatological conditions, they can also cause raised ferritin, which does not equivalent to the fact that you might have a blood cancer. So a lot of this perhaps would be better addressed by the medical professional that you've seen who did the ferritin. If it is done as a routine health screening, which I think a lot of people is included in, it would then also firstly depend on whether you have other symptoms. If everything else is normal, we sometimes do not need to further chase it just because there is one raised ferritin. However, if you do have other symptoms, then perhaps you should present yourself to a medical professional, show them the results that you have, and then they can take it further from there. Yeah.
Another question we often being asked is whether blood cancers are hereditary. So on lymphoma, majority of the cases are not. And usually they are sporadic. That means they happen without any clear cause. Some of them relate to viral or previous infection. Some of them are related to the underlying autoimmune disease or previous transplantation. So majority of cases, they are not hereditary. One more questions here is the cure rate after certain treatment. So just in very, very general, high-grade lymphoma is usually we call it complete remission after treatment, and we can only call it cure after 5 years when the disease doesn't come back. But beyond 5 years, there's still chance that the disease may come back, but of course the chance is very, very low. And whereas for low-grade lymphoma, unfortunately, because of low-grade nature, they are not curable and they are not curative, even you undergoing your initial treatment. So there's still low-grade lymphoma may recur even beyond the 5 years.
So there's one question, is low blood counts the same as unhealthy blood cells? So they are not equivalent. The low blood counts could be a reduced quantity, but unhealthy blood cells, sometimes we see abnormal blood cells that we don't normally see in the blood that comes out. For example, in the case of leukemia, there are other earlier blood cells like blast cells that comes up in the bone, in the blood counts, that we don't normally see in a normal healthy individual's full blood counts. So those two are different concepts. Low blood counts on the full blood count would refer to just a decreased number, but that doesn't necessarily tell us what it is. Whereas if we see unhealthy blood cells or abnormal blood cells that shouldn't be there, then it will point us in a different direction. I think there's another question. I don't know if the others want to answer it. How about this monitoring for recurrence on follow-up TCUs? I realize we didn't talk about sort of follow-ups. Maybe you can address that. Ida, you want to have a go?
Yeah, I mean, for leukemias, usually it will be by doing just blood tests. But of course, occasionally, even if the blood test is not may not be so worrying, some doctors may still prefer to do blood bone marrow in quite a specific duration, say every 3 months, for example. I think nowadays what is getting more and more useful is that we can use very specific and very deep markers that could identify very, very minute amount of cancer cells. So things like molecular testing, like NGS, for example, can really try to predict whether your cancer is starting to come up. And hence we may be able to start treatment earlier rather than when they relapse in the full blast phase. Sometimes certain types of leukemia or even like lymphomas and myelomas, we may do certain imagings as well. I think the main key is that physical exam and history is always part of the routine follow-ups when you see doctors.
Okay, so it is 11:43. I think that most of the questions have been addressed at this point in time. I would like to extend thank you on behalf of everybody to our speakers, Dr. Lawrence Ng, Dr. Melinda Tan, Dr. Nurul Ida, as well as to Prof. Ng Hing Ju for the opening speech. And if there are any questions or concerns, we can SGH can still be contacted, and we can address some of the other questions that are burning and itching at your minds. So with that, I'd like to thank everyone and end this session.
Thank you.
Thank you.
Thank you, everyone.